and has served on several advisory boards and committees of the National Institute of Health. A military veteran, Dr. Wilkes served 3 years as a major in the U.S. Air Force Medical Corps, where he earned the Commendation Medal for service. Please join me in welcoming Dr. David Wilkes, Dean of the School of Medicine.
Great. Hey, thank you, Barry. And I wish we could all be together face-to-face and not virtually. And I like to think that we're actually getting the hang of doing Zoom meetings. And after 6 months, I think we have it down pat. But hopefully this will go smoothly for this evening. So as Barry mentioned, I arrived here 5 years ago, and actually September 15th was my arrival day. So I'm just completed 5 full years. And what I'd like to do is to give you an update as to where we've come from from that time period. So could I have the next slide, please? So if you look at where we were 5 years ago, and if you look at the bullets on this slide, these are in essence were the asks of me for the medical school. So there's a request to rebuild the research funding portfolio with a target of $150 million in NIH dollars, and I'll talk about that later in the talk. Continue the innovation in undergraduate medical education. As most of you know, as UVA alums, UVA is regarded as one of the leaders in medical education. And not only do we want to maintain that, but we also wanted to improve that further, and I'll talk about that as well. Strengthening graduate education was another focus, as well as supporting academic success. There was an ask to increase diversity and inclusion, and we'll talk about that. We've had some extraordinary success there. And then things that might seem a little bit nuts and bolts and not very exciting, but we really needed to institute standards for administrative overhead structure and expense, and that allows us to get the work done, and we've made significant progress there. So next slide, please. So if you look at today and where we are headed in adjusting to a very rapidly changing landscape, many things that there are going on here. We need to figure out new ways of educating our students, and couldn't be more timely now with having to do all of our classes virtually or most of them virtually. Conducting research that was also impacted recently by the COVID pandemic. We're also providing clinical care in ways that are different than what they were just simply 5 years ago. And then there are changes in day-to-day operations, and this is something that literally is day-to-day that we have to keep on top. We have to stay on top of, mainly because of the changing landscape, in healthcare. But then at its core, we still do those things that allow the medical school to excel. So for all the other things that are changing, we still have one constant, and that is keeping ourselves true to our core in order to get work done. Next, please. So in the education space, in undergraduate medical education and graduate medical education. So in the undergraduate side of things, many of you know we established a Northern Virginia campus with Inova Health Systems. This is where our 3rd and 4th year medical students will do their clinical rotations. And that actually starts in this in spring of 2021. And this is a very exciting opportunity for us and for our students, because it allows us to provide a different and wider array of educational experiences during their clinical years. As I mentioned about being innovative in medical education, we developed entrustable professional activities, so-called EPA assessments. So this is not all medical schools in the country are doing this. We're actually leaders in this. And what the EPA refers to is having the ability to really determine if a medical student has a number of clinical competencies before they become an intern. So, and whereas many of you who went to medical school, we assume that everyone left with a set of skills. Now we actually document that, and it's something that puts us very much in a leadership position in medical education, in the country. We developed a leadership curriculum with the McIntire School of Commerce. This is for our medical students. Coming out of medical school is important, but learning to be leaders is also important in the practice of medicine, and McIntire has partnered with us in order to do that. We revamped clinical skills education and partly to the EPA activities, and now we have enhanced assessments of our graduation requirements, all of which add up to turning out students that are even better equipped to enter their residency programs. On graduate education, when I arrived, it was notable to me that I just assumed that if you've got your master's degree or a PhD from the School of Medicine, or if you did your graduate or master's training in the School of Medicine, that your graduate degree came from the School of Medicine. And actually, that wasn't the case. They came from the College of Arts and Sciences. So one of the things that we did in the first 18 months, we were able to move those degrees to the School of Medicine. So now all of the master's students and all of the PhD candidates, when they receive their degrees, it has a School of Medicine is on the diploma. We've had enhanced partnerships with the Medical Alumni Association to support the BIMS program. That's our graduate, the PhD graduate program, and other graduates. And we also established a Master's of Science and Commerce for recipients of the BIMS program PhD degrees. This is a notable item here. We know that nearly 63% of graduate students, when they get their PhDs after having done very elegant science, 63% of them do not pursue careers in academia, and this is on a national scale. They go elsewhere to do other things. And we wanted to prepare our students for what the workplace looked like for them. And this Master's in Commerce degree, in partnership with McIntyre, is a way for that to happen. We're really excited about, again, this is cutting edge in graduate education, and it's something that will benefit our students. Next up, please. So what does a class of 2024 look like? So almost 50-50 in-state, out-of-state. Women make up 56% of the class, and this number, women have had slightly higher percentage than men now on average for the last several years. 24% of our students are underrepresented minorities, for a total class size of 156. And as most of you know, our class size hovers around in the low 150 range, so that's really not a change. Our students are very strong academically. The mean GPA is 3.8 with an MCAT of 517. And tuition and fees, as you can see here, out-of-state tuition is almost $60,000 and in-state is about $50,000. But what is notable, we were now entering our 5th year of frozen tuition for medical schools. Many of you may know that UVA had the distinction of being one of the most expensive or the most expensive public medical schools in the country. And when I arrived in 2015, we decided to freeze tuition in large part because our competing schools were able to offer more to students, and cost was getting to be a factor where students may choose another elite school other than UVA. And so we've now have corrected that, and there'll be more changes coming in the next couple of years. Next, please. So if we look at the School of Medicine NIH rankings, and remember on the opening slide, I was given the job of getting the NIH funding up to $150 million over a 5-year period of time. And in essence, I'd like to say that we've done that. We started in 2015 with $100 million in NIH awards, and last year we closed out the books at $146 million. And I think this year will actually be above the $150 million mark. But note that the NIH rank has been somewhat static around 40, to the high 30s. So despite this, pretty impressive growth, nearly a 50% increase in the portfolio over the last 5 years in terms of NIH funding, our rank hasn't changed. And this is largely a function of all of our competing schools are also running very, very hard and fast in order to keep up. So there's still much more work to do in this space. Next, please. So when you look at the total amount of extramural grant funding, this includes NIH funding and non-NIH funding. The NIH funding to date for fiscal year 20 is now 147 million, and I think when we close the books out, we will easily eclipse 150 million. And the non-NIH funding, or those monies that are not coming from NIH, are at close to $90 million. But what is notable, the entire for the last 5 years, we've had steady increases in funding, and for the last 3 years, for fiscal years 18, 19, and 20, these are record levels of extramural funding, in the history of the medical school. It's something that we're really proud of, and we're hoping that we can maintain this solid trajectory going forward. Next, please. So what about support for research? We have brilliant scientists, both clinical and basic scientists, and how are we supporting these extraordinarily talented individuals in order to get their work done? Well, now 3.5 years, almost, it's 2.5 years ago now, we were successful in competing for an NIH-funded clinical and translational science award, what is known as the CTSA. The CTS, there are 60 NIH-funded CTSAs in the country, or 60 or 61. So we've now entered a very elite group of schools. And when we look at medical schools, there are 3 things that make schools very distinguished. One is having a CTSA, the other is having a medical scientist training program, or the MD PhD program, which is funded by NIH. And the last is having a comprehensive cancer center as determined by NIH. So right now we have 2 of the 3 with a CTSA and an MSTP. We also were fortunate in getting monies from the state to build a $9 million GMP facility for cellular therapeutics. So what does this mean? These monies were designated to develop a very large facility to develop immunotherapeutics for cancer, CAR T cells, actually designing very specific CAR T cells, not buying them from other companies, but actually making our own, which we've now done. This facility now, just also in the last few months, has gone one step beyond, and they're actually in the process of collecting convalescent serum from COVID positive patients. And so this is another aspect of the $9 million that we've been able, of this $9 million facility that we've been able to leverage in order to advance care for our patients. We've made really great strides in our imaging capabilities with newer MRI capabilities and also PET CT. And these are not just for patient care, but also for research. We have purely research focused scanners. And training grant support for principal investigators, this 4th bullet. When our investigators compete for a training grant to train the next generation of scientists, typically it doesn't come with any salary support from the National Institutes of Health. And we've been able to provide that for those who've been successful in competing for these training grants. And Encore, this next bullet, this is the software that allows us to support clinical trials. This is a multi-million-dollar investment that allows us to really streamline our conduct of clinical trials. And finally, for this slide, over the past 5 years, the School of Medicine introduced over $17 million in new technology and instrumentation in our cores, including $9 million from NIH. These are SIG grants, or instrumentation grants. So these are large grants that allow us to buy new instruments in order to allow our investigators to keep doing the cutting edge research. Next up, please. And so what about for academic success? So we have great investigators, but how do we support the faculty as they strive for excellence? We developed the Penn Scholar program, named after Dr. Vivian Penn, many of you know as an alum of the medical school. And this program invests in mid-level faculty. We actually provide $120,000 a year for 3 years to support faculty members who are outstanding individuals to do work that they otherwise would not be able to do. We have a very robust junior faculty development program that's led by Dr. Susan Pollard, who is our Senior Associate Dean for Faculty Affairs. She also has developed a very strong department chair onboarding program, and it's also a leadership development series. And we've also been able to revamp our promotion and tenure process. Something that we're really excited about is when we look at the number of women professors, we went from 45 in 2016 to 76 today. So nearly a quarter of our School of Medicine professors are women. This now exceeds the double AMC average, and it's something that we're quite proud of. And the last is the conduct of departmental annual reviews. We meet, my team, my cabinet meets with the department administration for each of our departments, all 29, and we sit down and review all of the missions that operating in the school, so we can ensure outstanding operations going forward, but also we get to know some exemplars where some departments are doing things that others are not, that are truly remarkable. And we get to share ideas and literally cross-fertilize innovative practices. Next, please. So in diversity and inclusion, and although this slide would be in here anyway, it's incredibly timely in the current state of affairs in our country. So we were, in 2015 and 2018, preceding all the current events in society today, we've done climate surveys in order to get an assessment of where we are in diversity and inclusion. And that out of that came a number of different plans, all of which are listed on this slide. We developed a diversity consortium. Each department has a diversity liaison, and every department in the schools develop diversity plans for recruiting faculty or trainees. We developed diversity days and second look programs for intern applicants looking at UVA as a place where they might do their training. Unconscious bias and safe place training is widely available and widely utilized. And we actually changed how we look visually, so that many of the pictures outside of departments that had lined with past trainees for the last 30 years that frankly were not very diverse, we've actually changed that and made the environment looking more welcoming for individuals from underrepresented backgrounds. And then we also provided tools and training to help people respond to bad behavior. The program is called Stepping In. This program is, although we use it and it was developed here, Dr. Peggy Pluz-Oaken was the leader in this, we've received national recognition. And in fact, many schools now come to us to learn how to do this. It's something that we're quite proud of. And in fact, we ended up getting the program copyrighted because it was so successful. Next up, please. So just graphically, what do the classes look like? So I mentioned that 24% of our current medical student class are underrepresented minorities. And you can see the trends here from 2015 and onward. You might note in 2018, there was a significant drop off, and that was a year after the August 17 events in Charlottesville. And we thought we might have a dip there, but we rebounded and we're looking quite strong now. And this trend is there even not just for medical students, but on the next slide, you'll see that for our residents and fellows. We started with single digits in terms of percentages for residents and fellows, and now we're up into the mid-teens for both. And this is extraordinary growth, and few medical schools in the country are able to show these types of data. And again, it's something that we're really proud of, but our faculty did this, our graduate medical education group, led by Dr. Susan Kirk and working with Barry Collins, were able to put together programs that allowed us to do this type of aggressive recruiting. And it's paid off. And I should mention, with all of these data showing the increase in underrepresented individuals at residents, fellows, and I'll show you faculty data next, as well as medical students, it's important to note this is not about numbers. We have a mandate to train the physicians that look like the populations that we're going to serve. And as the country gets more diverse, we're trying to address that need. And that's the reason why we're going in this direction. It is about what's doing best for our patients. Next, please. And in the graduate programs, our PhD program is now becoming incredibly diverse. And now nearly a third of our PhD students are underrepresented minorities. Next up, please. And then in faculty, as I mentioned, we have been fairly flat in terms of the percentages of underrepresented minority faculty. And now just in the last 2 years, we've been able to, we've increased that number. The increase from 4.4 to 5.4 does not seem to be dramatic, but it's an additional 20 plus faculty members. We are still shy of the AAMC average, but we're working very hard not to just meet that, but to exceed it. Again, it's what's best for our patients, and that is having a diverse faculty that can not only teach, do research, but also provide clinical care. Next up, please. And so we've been recognized for our efforts in diversity and inclusion. The School of Medicine has received the Higher Education Excellence and Diversity Award eight years in a row. I will stop. There's embargoed data for this year, but I won't mention it, but it's positive. We've also received a recognition from the LGBTQ healthcare and the Human Rights Campaign as an equality leader. And blackdoctors.org has recognized the UVA health system as one of the top hospitals for diversity. We got this award last year for 2018 and 19, and again, it's been repeated. So something, again, a lot of efforts have paid off, and something that we're really proud of. Next, please. One of the other aspects is, and this may seem somewhat mundane or expected, but when I first arrived at the medical school 5 years ago, and I was asking for data about space utilization, salary support on grants, and a number of other things, we literally had manual data extraction, and a lot of that was on paper. We didn't have a streamlined process. We didn't have one big data repository. We didn't have a data warehouse, and there's so many things that were not there. Our team really did some extraordinary work, and we now can look at many aspects of the medical school through a data repository, and this is called the Business Intelligence Data Portal. We can look at individual data on for each faculty member and for many operations across the school. And again, I have to admit, I'm very proud of this, because we now are able to do data-driven operations in real time and not wait for data to be put together. And out of the Business Intelligence Portal, we're able to do monthly school and departmental financial reports, so that the departments don't have to wait till later in the year in order to see how they're doing. This happens monthly, and I get a chance to review that data every month. And this is all supported by new budget and financial supporting software. We even brought Lean into the dean's office. We wanted to see what our practices were, where they could be optimized. So the entire dean's office went through a Lean management exercise, and we've been able to really enhance what we're able to do in support of our faculty and staff in the school. And we also needed to do enhancements in documenting standard operating procedures. Again, seems mundane, but it was in need of a lot of work, and we're able to do that. Now we have very standard procedures going forward. Next, please. So what about tomorrow? So the first bullet, charting a new path in changing times. So most of you know that there's a search for a new medical school dean. So that means this time next year, I will not be doing this address. And a lot of folks have asked me, so what happened? And I'll tell you exactly what happened. A year ago, President Ryan asked me about signing on for another 5 years, and I told him, I don't have 5 years left, and he thought I was dying from some malady, and I said, no, it's not really about that. It's really a function of this sounds self-serving, but something important to me. I have a couple of grandchildren out on the West Coast, and now two years and 3 months, and one 3 months old, and I want to be able to spend time with the grandkids. And being a medical school dean on the East Coast doesn't allow me to fly to California a lot and have that free time and family time. And that's really the driver for why I'm making the transition. We are facing some interesting times in finances, and financial constriction is written here. So we learned this year, not just we, but everybody in the country learned that healthcare is no longer recession-proof. Many of you have heard the term that the only recession-proof industry was healthcare, but that's not the case. The COVID epidemic, changed all of that, and we, as other medical institutions, are adjusting to that. And the pandemic has really changed the way we're doing a lot of things. But I will tell you now, as of today, and certainly for this past month, the hospital is full. Full and packed. Clinical operations are running, very strongly, and we're coming out of this, on the other side. And I anticipate the coming years are going to look quite good. With that, in order to get to the looking good piece, it will require health system strategic planning. Dr. Craig Ken, who's the new EVP for Health Affairs, will be leading that in this coming year. And we also have the UVA School of Medicine and the Innova campus. Students start there, as I mentioned, in the spring of 21, but we're really excited about where that's going to take us going forward. And we continue to enhance and support team science and transdisciplinary grants. And this year coming, at the end of 21, this is our time to compete for comprehensive status for our cancer center. And I think our odds look very good in order to achieve that. So next up, please. So we couldn't do any of this without support and from all of you on the call this evening. And I have to thank all of you and those who are not on the call tonight, as well as Barry Collins and the Medical Alumni Association. Without philanthropy, we really couldn't do much of anything. And I think it's more important today than it ever has been, certainly due to the uncertainties linked to the pandemic. But with philanthropy and ongoing support, we've been able to do numbers of programs and events for alumni, students, and faculty, our white coat ceremony, the match day, and others. Very strong student and alumni networking programs. There's also financial assistance provided by the Medical Alumni Association in the form of scholarships, conference expense reimbursements, and numbers. And we're also able to support the students who have unexpected one-time needs, and something that, because of your generosity, we feel very good about supporting our medical students, and we're here to help them get through school. So I want to again say thank you, for that. So next slide, please. So that brings me to the end, and I'm hoping that I finished on time, and Barry will tell me if I didn't. But I just want to say thanks to everyone on the call today. This is the school's in a very good place, and I'm proud of where we have come. There is much more work to do, and I think the work will be cut out for the new dean, because the landscape in academic medicine is changing very quickly. But I think we're well equipped, and we will have the leadership in place, to excel. And then I'll end this with just saying once again, thank you. Without you, there's very little that we could get done, and we've done well, and I hope that we've made all of you very proud, in the process. So Barry, I'll end here, and perhaps we have time for some questions. Thank you.
Sure. Well, thank you very much, Dr. Wilkes. That was very informative, and it looks like the School of Medicine is in a great place right now and headed in an even greater direction. We do have time for questions for Dr. Wilkes. If you could use the Q&A function at the bottom of your screen, if you just type in your question, and then I'll read that off to Dr. Wilkes, and at the best of his ability, we will be able to answer that. And if we are not able to answer that, we'll follow up with you individually. So Dr. Wilkes, first question. I have heard that there are not enough first-year residency positions for U.S. School of Medicine graduates. Is this true? And what is UVA and the AAMC able to do about it?
So it is true. I would suggest to you that some of the medical schools that so for UVA, it's not been a problem, for us. But what we've not been able to do anything directly is, the residency programs are funded by, through programs linked to CMS or Medicare. There has been intense lobbying by the AAMC, at the federal level in order to expand, monies for that. But the funding for that has not changed since about 1991, if I remember the date, correctly. But as healthcare needs change and the needs, actually increase, there is a need to expand graduate medical education, and the AAMC continues to push very hard, and we are very much in support of the AAMC, and I'm hoping that we'll get some changes going forward. But it's a key question, and one that it's a challenge. Fortunately for our students, our match rate is 99 or 100%. We've not had a problem with that. And in fact, our students end up going to the best institutions. But nationally, as the question raises, this is a concern for all of us going forward.
Thank you, Dr. Wilkes. Our next question, if you could expand on your definition of the lean processes that are taking place in the dean's office.
Oh, so the lean processes. So using lean management. So we're looking at how we run our finance offices and making sure that individuals are operating to the top of their abilities, and they're doing not multiple things that are very different, but individuals are focused on individual jobs, and we're making sure that folks can actually get the work done. We really didn't have an organized process for that going forward, and things weren't very streamlined. And so going through a process known as an A3, for those of you who deal in the lean space, we get a chance to process map every step of every operation that's involved in a school, or we did that. And so that allowed us to see where things worked really well, and it also allowed us to see where there were opportunities to improve performance. And at the end of the day, it limits the frustrations that our staff have when they're trying to get things done, because we've mapped out very, very clear directions in order to make the operations go much more smoothly. And it's worked out very well. And we've taken ambiguities out of the system and made things much more efficient. It's literally bringing the business world into the operations, or the way that businesses manage themselves. We brought that into running the medical school.
Our next question is it possible to receive a set of your slides? Just for everyone in the audience, we actually are recording this session, so it will be available for playback, and it will be available through the Medical Alumni Association website, and I believe that we're going to be sending it out to the participants as well too. But we will make sure that we have access to this presentation because we are recording the session here. And then Dr. Wilkes, our next question is, how does the pandemic impact medical student training process?
Oh, great one. So in March, I'm trying to remember, I should know the date. It's seared in my memory. All of our classes, literally those in-person instruction that were not clinically based, that were not in the clinical arena, they went online, literally in a 72-hour period. The great news is that most of our medical education that's preclinical has an online component anyway. All the classes are recorded. You could do many things online, but we literally had to take students out of the medical school, and all of those things went online, and that's been actually very, very much seamless. There are still group learning exercises. We were able to do those online, but in the clinical arena, where we did have a number of changes, going there, and in fact, all of the medical students that were doing clinical work on rotations were taken out of the medical center for a period of time. And the main reason for doing that, if you may recall, when the pandemic was very, very early, the data was showing that almost those individuals that were in an age demographic about 22 to early 30s, up to a third of them may be asymptomatic carriers of COVID. And that meant these individuals, and which the age group of our students, may have been asymptomatic carriers, and then possibly infecting other individuals, in a healthcare setting. So there was a mandate put out by the AAMC to take all the students out of the clinical arenas, and then which we did. But all of our students are back now. As of June 30th, everyone is back in the clinical arena, and the preclinical work, continues to go on. And that is remote as well. And I should mention to all of you, as I'm sitting in my office this evening giving this, but the medical school, all of the administrative work is remote. So it's not just the medical students, all of us are pretty much remote, except for the clinical, the students on clinical clerkships. They are back in place and learning as they would. We have adequate protection in terms of PPE and other things to make sure that they're safe and others around them are safe.
One comment for you, Dr. Wilkes. Thank you for your service, Dean Wilkes. We appreciate all that you have done over the past 5 years, and you will be missed. So coming
Well,
from.
thank you.
Sure.
Right. Thank you very much.
And next question in regards to primary care, what are we doing to recruit, train, and inspire careers in primary care?
Well, we're doing a number of things. You know, the primary care, it's very interesting. If you looked at the U.S. News and World Report that came out, we're in the, I think, number 6 in the country now in primary care. And it's an amazing rise from the 20s up to number 6. And I think that reflects a lot of the emphasis that's placed on primary care in the clinical setting, particularly, you know, for our students. In the last 2 years, now almost 2 years ago, we recruited a new chair of family medicine who's been very active, you know, in this, you know, in helping us to train medical students and for them to gain interest in family medicine, and in internal medicine and pediatrics, very active. These are some of the highest scoring rotations. So I'm actually not surprised that we're seeing, you know, this a push into primary care. The other thing that we did now, just in the last, I'm trying to remember the dates now, it's almost 2 years. We now have an established partnership with the Charlottesville Free Clinic, something that many of you knew about or may have been involved with, but it was not a set elective or clinical rotation for our students, and it now is. They are a partner, and it's something that the students wanted, and it is truly, you know, a very in-depth primary care rotation. And it's not the typical one. The students see the front end of what the patient's needs are, really addressing social determinants of, you know, of medicine, and on the back end, looking at how patients are challenged for paying for medical care, and others. So it's not just about seeing the patient with a preceptor; it's the full spectrum of healthcare delivery and how our patients are impacted. You know, as you know, from local environments all the way to the other end, which is, you know, socioeconomic factors. So a lot of interest, and the student groups are also very active in this area.
Thank you. And our next question, what can we do as alumni and donors do right now to support the School of Medicine?
Well, there's Barry Collins. There are various ways to support us. And the one thing that we need, and I would say this, you know, over and over again, is that scholarship money is always very important, you know, for us going forward. So if I had to choose one thing that our medical alumni could help us provide, is additional scholarship support, you know, for our students. Our students do well, much better than the national average in terms of medical school debt, but the numbers are still very significant, and anything that we can do to offset that is a priority for me. And that's one of the reasons why we froze tuition, you know, now 5 years ago. So you know how to get to Barry, and he will be very welcoming of your contact.
Thank you. Our next question is, with the opioid epidemic and fatal drug overdose crisis exacerbated by COVID-19, how is UVA educating physicians on diagnosis and treatment of substance use disorders?
Actually, you know, interesting that this question is raised. It's now the planning for the new emergency room towers, and it's now open and operational as of just it's about 6 months right now, almost 6 months. As that was being planned a few years ago, and it was an area specific for treatment and detection of opioid abuse, and so it's something which is really central to the mission of what we do here, and it's. The timing couldn't be better to have that facility open, because as the question is raised, this is a major problem, and the pandemic has only made that problem much worse. But we're actually well equipped in order to manage that and have facilities designed to deal with that directly.
Thank you. Our next question, and just as a reminder, there's still some time to ask some more questions. Just use the Q&A function down at the bottom of the screen. Just type in your message and we'll get it to Dr. Wilkes. So our next question is, what would you project as a fair tuition for UVA medical students?
A fair tuition? That's a really hard question because our medical school tuition does not cover, it's really not close to covering the full expense for teaching and training, an individual medical student. So I'm not sure. I don't know how I can answer, fair. And what our students get in terms of the return on investment, they get a first-class medical education. And I'm not just saying that because I'm the dean of the medical school. We're regarded as one of the leaders, and the experience is really as good and better than most schools, out there. But I don't know. It's hard to put a price on fair. If we were not a state school, that would be a different discussion. But the challenge we have is we have very little state support, and we have to charge what it costs to be educated, and that's not even sufficient. And things are heavily subsidized on top of that. And that's where, again, as I mentioned, philanthropy is very helpful for us. But I have to think about the fair question. It's expensive, certainly, but I'm not, and I think we can justify the expense, but I'm not sure what fair would mean. The fair market value of medical education, depending on other schools, where there are schools more expensive than us, and then there are other schools that are much less expensive, many state schools, but the states provide much more state support, and unfortunately, we're not in that environment.
Thank you. And then another question for you, Dr. Wilkes. Can you address the clerkship rotations of internal medicine, geriatrics, and family medicine getting merged together?
Oh, sure. I'm happy to answer that. Many of our students felt that the experiences that they had in those clerkships were very similar, and they thought that one of those could be eliminated. But in the other one, and so that was one aspect of it. The students thought there was something that it could be done, and then simultaneously we were having increased difficulty in finding community preceptors to take students. And then combined with that, many of our students were complaining that they were spending too many weeks away from Charlottesville, and many students were actually uncomfortable with going to very rural communities. And admittedly, many of those students who were uncomfortable were our underrepresented minority students. So the curriculum committee got together and with a lot of support from faculty, made the decision to combine the clerkships. What had been a little challenging before now seems to be running smoothly. So I hope this is something that that will continue.
Thank you. And Dr. Wilkes, I have data on this if you don't have it current, but what is the current debt load with which UVA medical school students graduate, and how does it compare to other medical schools in the country?
Do you have that data? We were about $160,000, and nationally was in the low 190s.
Yeah, our most recent is we're 164,000 compared to the national average of 180,000. So we rank in the 35th percentile on debt load for all medical schools in the U.S. and Canada. Next question is, what is your opinion of the decision to have USMLE Step 1 as a pass-fail exam by January 2022, and will this trend continue in other benchmarks?
So the first question, so the USMLE, the Step 1 question, this has been, so I'm a member of the Council of Deans, which all the deans of medical schools in the country get together at AAMC meetings a number of times, during the course of a year. And the Step 1 question has been out there for years, well preceding, my arrival here as dean. But the end point of this, as now pointed out, is it goes from a numeric score now to a pass-fail score. The advantage is that having the students not focus so much on, I got to get a good step one score, they can now focus on their medical education that's happening, in real time with them. And they're not looking backwards over their shoulders thinking, I have to really nail that step one exam. The challenge with taking the numeric score out, as everyone likely knows, for those training programs, residency programs that are very competitive, many of those programs would just take a step one score, pick a threshold and say they were not going to interview any student that had a score lower than 200 something, whatever that value is. And for very competitive programs like ortho and ophthalmology and others, that's certainly what was the case. But when you look at step one exams and look at the quality of the practicing physician in the out years, there was absolutely no correlation. That score really didn't predict who was going to be a good doctor or not. And so that was part of the driver. Since it wasn't a predictor, then should it just go to be pass fail? And there are other nuances in how the test is constructed as well. It was not designed to be a measurement of caliber. The test just wasn't set up to do that. But that creates a challenge. So now you have thousands of applicants looking at residency programs, and what is a differentiator? And so for us, we'll be able to have the EPA scores. One of the things that I'm very excited about, the entrustable professional activities, can identify those students who are going to be clinically very, very competent. With regard to, and we'll have a leg up on that because UVA, we're at the leading edge of that. And the change for the step one score is coming up in it'll be 22 if I remember the date correctly. As for other standardized exams, I don't see them going to a pass-fail format. There's been no discussion about that nationally, and I don't think it's practical to consider those to be pass-fail because they're measuring different things and different sets of competencies than is step one. But for step one, I actually think it's a good idea. And the other one is that focusing on the practicing of medicine through the EPA is likely to diminish some of the burnout that students face because they get so focused on step one scores. So I think it's a good thing. And in fact, I was a real proponent of that. And another aspect is it will also help, I think, diversify many of the more competitive residency programs when you take that scoring system out, and you're really looking at folks who are going to be really good doctors. And so I think it's good, and we're going to learn something over the next few years as a result of the scoring system changing.
Next question, Dr. Wilkes. Does the School of Medicine have any formal programs to address the issues of physician burnout and wellness?
So there are many programs that are involved, not just in medical school, but also in the School of Nursing. And there are a few programs, newer programs that have been developed just in this past year. But yet it's still not enough, right? As yet, and that's something that Pam Cipriano, who's the dean of the School of Nursing, and as you know, the School of Nursing is now part of the health system. She's taking a lead role in working through some additional processes to help us to deal with the issues of burnout. We have it at every level. It's not just our faculty. We have it in the nursing staff, and we also have it in the medical students. So this is a system-wide problem for us that is going to require system-wide types of management. And Pam is leading the development of those processes going forward.
Well, thank you, Dr. Wilkes. I don't have any more questions queued up. I don't know if you have any closing remarks, and I'd just like to say a few words after you're finished, just as for follow-up. So if you have any closing remarks for our attendees this evening, that would be great.
Yeah, I hope to interact with some of you at some of the venues before I transition. You know, the search for the new dean is it has started, and I agreed. You know, I was asked to stay until that person arrived, up to 1 year, so up until August of next year. And hopefully I will get a chance to interact with some of you. But in the event that I don't, I started with thank you, and I'm going to end with that. You know, without you, a lot of what we do would not happen. And I know a lot of medical schools elsewhere, but I've not seen the type of loyalty from alums from UVA that exists, you know, elsewhere. So your loyalty is very important, and I've had the pleasure of leading for the last 5 years, and I truly feel privileged to have had this opportunity. So thank you very much for your support.
Well, thank you very much, Dr. Wilkes. I want to give a special thank you also to all of our attendees this evening. As you know, we're in a challenging time right now, and normally we would have this address in person and we would be socializing and getting to shake hands and hug. And we certainly miss all that. We miss all of you, and hopefully we can continue this engagement over the course of the academic year here. We have many programs that we've been still conducting virtually, a lot of them connecting our alumni with our students. We've had career panels just about weekly over the last 2 months. Many other things coming up. We are going to do our host program virtually this year. So if you're one of our host volunteers, be on the lookout for information about that. Also, one of our attendees tonight is my good colleague, Tara Hackenberg, and she's our Director of Development. And I know the question was posed out there, how can we support the School of Medicine? You can certainly contact our office at uvamedalum.org, and I would be happy to connect you with Tara and her team. They work with our alumni across the country and help them understand philanthropic ways that they can support the School of Medicine. And they're a great team. We've been working together for years, and they're a great resource. We are going to be sending this recording out to all of our attendees, so you will be able to have access to seeing all the slide presentation again on that recording. If you've thought of a question after we conclude here tonight, please again just reach out to us at uvamedalum.org, and we'll be happy to answer your questions. And again, thank you all for attending. We certainly appreciate everything, and we hope you have a great night. Stay safe, and looking forward to when we can reconnect again. So thank you all, and have a great evening.